Today's patient is Sally, a 10-month-old, 25-pound intact female beagle mix presenting for a spay. During her physical exam, she had a temperature of 100.9 degrees Fahrenheit. Her heart rate was 120 beats per minute. Her respiration rate was 20 respirations per minute. Her mucous membranes were pink and moist, and her CRT was less than 2 seconds. Based on Sally's weight, this is the anesthesia protocol that I've come up with. Her pre-meds would be ace-promazine, atropine, and buprenorphine given IM. Her Onsior injection will be given 30 minutes pre-op sub-Q. For induction, she'll be receiving propofol IV. For post-op, she will get Onsior oral 20 mg tab once a day by mouth for 3 days after her surgery. For her PRI, I got 113.6 mLs per hour or 56.8 mLs per 30-minute surgery. And for her drip rate, I got 1 drop per 2 seconds. This is the anesthesia machine, and it must be checked before using it for surgery. First, you will have to go into the oxygen room and check that the oxygen tank is above 500 psi. If not, you must change the tank. Then you will check the regulator pressure gauge and make sure that it is always reading 50 psi, as this is the pressure that goes into the anesthesia machine and it should never change. Also, if there is a change, there may be a leak in the line or someone may have left the flow meter on at the machine, so you might want to check this. Then you'll go and check the flow meter. You will turn the flow meter to about 1.5 liters per minute. Verify that this is staying stable and not moving up or down. Then you will turn off the flow meter and the ball should return to 0. Do not use the machine if the flow meter does not function right. At this point, you will check your vaporizer to make sure that it has adequate liquid level. If not, you will fill it with the correct liquid as necessary and tighten the cap. Once you've done that, you will check your CO2 absorber, and sometimes if it has been exhausted, it will turn blue or purple. If this is the case, you must remove it and refill it. If there is no dye, then you must take a piece of the absorber and break it. It should break and crush fairly easy, and if it doesn't, then it should be changed before your procedure. You're now ready to check your system for leaks. At this point, you'll close your pop-off valve and occlude your patient's tubing that will connect to their endotracheal tube with either a finger or the palm of your hand. Then you will fill the system with oxygen using your O2 flush valve until the circulmanometer is reading 30 centimeters of water. Your pressure shouldn't decline more than 10 centimeters of water in 30 seconds, and if this all checks out, then you can open your pop-off valve to release that pressure. Common sites for leaks would be your rebreathing bag, your one-way valves, hose connections, CO2 canister, if it's not tight enough, and if you find any leaks, you must fix them and recheck the machine. Do not use it if it's still leaking. After this, you can finally check your pop-off valve and scavenge system, and you'll be done checking your machine. In this case, you will open the pop-off valve, occlude your patient's tube, turn on the oxygen to 4 liters per minute, and then you will check the manometer and make sure that it does not read more than 2 centimeters of H2O at this flow rate. Because if it increases, then there's something keeping the scavenging system from emptying properly, and you need to fix this prior to use. Also, be sure to check that your scavenging system is not expired. If it has gained more than 50 grams, you must change it. And for this surgery, I will be attaching a Y-piece tubing for my patient and a 1-liter bag based on her weight. Before we can begin our procedure, we need to make sure that we have all the proper supplies necessary. As an anesthetist, you should make sure that you have an endotracheal tube that fits your patient. For our patient, I have chosen a 6.5 millimeter tube based on her weight. I also would collect tube tie, lube if needed, gauze, a laryngoscope if needed, and a syringe to inflate the cuff. You may also want to have ophthalmic ointment for the patient once they are under anesthesia. As the surgical assistant, I will make sure that in the recovery area we have a cage set up, including a cage card, floor mat, bedding for our patient after their surgery. I would also make sure that the fluids are set up in the surgical suite. I would also make sure that the surgery table is set up with warming devices, table ties, and a V-trough if necessary. You also need to get out the proper surgery pack, drapes, scalpel blade, and suture and place them on the Mayo stand in the operating room. In this case, we would be using a 2/0 PDS suture, as that's what the surgeon prefers. We would also place gowns and gloves in the scrub room for when scrubbing in. Finally, as general circulating nurse, I will make sure to organize the clippers with a 40 blade, any prep materials, and catheter materials, including tape, Chlorhex scrub, alcohol, 22 gauge catheter, cap, and flush. I will also make sure to draw up and record any pre-anesthetic medications as well as induction drugs, and make sure that the station prep kit as well as the surgical station prep kit are both fully stocked for when we need them. Now it is time to prep the patient. Here I am demonstrating an IM injection of pre-meds in the semitendinous muscle. Once our patient has had time to let their pre-meds kick in, I will be placing a lateral saphenous catheter since this is a canine patient. First, I will clip the area, and then I will alternate between scrubbing with a scrub and then alcohol. I will then take my 22 gauge catheter and I will find the vein and insert. Once I get a flash of blood, I will remove the needle and then I will place an injection cap for my induction drugs. I will then secure the catheter in with tape. As I am securing with the tape, I will make sure to tab my ends so that it is easy to remove the tape once I need to remove the catheter of this patient. At this point, unfortunately, the tape did not make it all the way around my stuffed animal's leg, but of course, in a real situation, you would make sure that this tape does wrap all the way around and make sure to tab accordingly. Once you're done taping in, you will flush your catheter to make sure that it is secure and that you can move forward with induction. I will now take my induction drug of propofol and slowly inject the animal. Once I feel that they have had enough to effect, I will then check their palpebral reflexes, their pedal reflexes, and their jaw tone to make sure that they are ready for intubation. Once I feel that my patient is ready to be intubated, I will then place them in sternal recumbency, and then I will have my restrainer hold for me while I pull the tongue out and look for the epiglottis and the glottis to place the tube. I will then pull the tongue out and go in. Some ways to check that you're in are cough, fogging or moisture in the tube, and palpation of the tube. Once you believe that you are in, you can inflate the cuff and tie the tube to the patient. Attach your patient to the machine and put them at 1.5 to 2 liters of oxygen per minute and 1.5% ISO. This can change depending on how light or deep your patient is. Then you will place them in dorsal recumbency and express the bladder to make sure that they prevent contamination of the surgical site and also to keep this bladder out of the surgeon's way. You will then clip the area from the xiphoid process to the pubic symphysis in all directions with a 2 clipper blade width. You will then also vacuum to make sure that there are no hairs left. At this point, you will use a target pattern to scrub the area. This will be your dirty scrub. You will use scrub, then alcohol, and interchange for 3 times. At this point, you are ready to move your patient. You will detach them from their machine, move them to the OR, and reattach. Then you will place gloves on for your final scrub, in which you will do a target pattern again with your scrub and alcohol, alternating 3 more times, and then you will spray with betadine. Your patient will need to be in dorsal recumbency with their hind legs tied straight back and their front limbs pulled straight forward and crossed. You should also have half hitches on each leg twice except the catheter leg. You can also use a V-trough to stabilize the thorax if necessary. Now I will be performing a jugular venipuncture. So here I switch hands, but I will be placing my thumb into the thoracic inlet and then using my pointer finger to extend the neck so that I have better access to the vein. I will then put some alcohol on the site and go in bevel up. I will aspirate, and if I have blood, then I will continue to aspirate as much as I need. If not, I can always redirect, as seen there. Once I have enough blood, I will let up, place my thumb over the site where I place my needle, and pull the needle out, and I will hold for a few seconds to clot the area. Now that the surgery is complete and successful, as a surgical assistant, I will fill in all patient medical records, fill out their SPAY certificate and have the DVM sign it, and also fill out any post-treatment sheets and label medications for that patient. I will also check on the patient that afternoon, check their vitals, make sure that they're walked, and also label and organize all their medications and place them in the appropriate place. And then for 3 days after the surgery, I'll be responsible for returning, checking their pain level, making sure their surgical site is not having any complications, also check that they're eating well and that they have a good body temperature, and also continue to monitor their incision until the sutures have been removed or healed. As the general circulating nurse, some of my responsibilities would include cleaning the surgical scrub room of any used materials, also cleaning and disinfecting any instruments used during lab properly, repacking instruments, drapes, brushes, gowns, and other equipment, also washing the endotracheal tube and esophageal stethoscope, and cleaning the surgery room and prep area. Once that is complete, I will also make sure that each prep bucket is complete with fully stocked materials for the next surgery and record all the procedure information in the patient's medical record. Once the procedure is done and my patient is ready for recovery, I will turn off anesthetic gas but leave the patient on for 5 minutes of oxygen. During this time, I'll deflate the cuff and untie the tube. I will also make sure to get a final temperature, which in this case was 99.5 degrees Fahrenheit, which is great. The patient is ready for recovery at this temperature. If the patient were below 98 degrees, I would have to leave them on a heat source until they warm up before putting them in recovery. Then I would also remove bandages and any IV catheters that were placed and clean and dry the patient's surgical site. Finally, after I see that the patient has swallowed 3 times, I will then remove the ET tube from this patient and place the patient into their recovery cage. Finally, I will place this anesthesia record that is fully filled out with all of the patient's information into the proper folder to get finalized.